So welcome everyone from many countries in the world. I'm very happy to be with you today for this webinar, along with Professor Carole Clair, who's our guest today. Thank you for joining us tonight, today, many different time zones for this session. Professor Clair, welcome. I just wanted to introduce you quickly and give a bit of a background on yourself. You're an associate professor in medicine at the University of Lausanne in Switzerland. You work as a general internist and researcher at the Center for Primary Care and Public Health, Unisanté, where you currently co-direct the unit of gender and health. In terms of training, after your clinical training, you did a postdoctorate in 2009 until 2011 at the Tobacco Research and Treatment Center of the Massachusetts General Hospital in Boston, in the US. And in parallel, you completed a Master of Science in Epidemiology at the Harvard School of Public Health. Quite impressive. And you obtained your Master of Science in 2012. You've developed a really strong research interest around gender and health, and you currently lead several research projects to better understand the influence of sex and gender in clinical medicine, why you're here today. And you also lead a project to implement gender in the pre-graduate teaching of medical students at the University of Lausanne. And you're a member of the European Commission's Gendered Innovations 2 Expert Group. Is that correct?
Yes, that's correct. Thank you very much.
Great. I didn't forget anything. That's a really impressive curriculum.
Thank you. I'm very happy to be here, and I say hello to all the people who are attending. And I cannot see you, I cannot hear you, but I know you're present. So thank you.
Yep. So before we launch the lecture, because we've recorded a few weeks ago, we'll notice that we don't look the same, and Professor Clair doesn't look the same in the lecture. So I'd rather say that it has been recorded a few weeks ago, and it's subtitled in Spanish. So Spanish people, please don't leave quite yet. We want to know a bit more about the audience, about you who are listening to us, and we want to understand maybe how the lecture can be beneficial in tackling gender differences in pain perception. So for this, I'm going to administer 2 polls. And we are waiting on you, the audience, to answer. So the first poll that you will see on your screen right now, and you can vote, please vote, is who is more resistant to pain? Who do you believe to be more resistant to pain? Men or women? Or maybe are they equally resistant to pain, do you believe? I'm still collecting responses. About half of you voted. It's going quick. It's going quick, and it's changing quick as well. It's really interesting. Just gut feeling, or maybe because you know, just vote, just to check whether we are going to talk about this during the lecture. So let's just see about that. I'm giving you 2 more minutes, or not minutes, but maybe a few seconds more. Come on. Okay, so there's one answer which is really strong. Professor Clair, you will see that. I'm closing the poll right now. So thank you very much for answering this first poll. And you should see the answers on the screen now. Professor Clair, maybe you want to
No, I get the same type of answer when I ask students, medical students, or physicians. So you will see that we share this belief, but it's not quite correct. But it depends how we also estimate resistance to pain. So you will have more information, and we can also discuss this later. But actually, when we look at data, men are more resistant to pain, but we will discuss this later.
Great, thank you very much. So it's going to be beneficial to see to hear the lecture and to see it. We do have a second poll for you guys, and it's about the factors that can influence pain perception. So you can see on your screen which factors can influence pain perception or expression. Sexual hormones, past experiences, age, social gender norms. So please vote on the one that you believe to be the most important factor you think that can influence pain perception. Then we will see the percentages, and we can discuss. It's going quick, it's going fast. Once again, there's one answer that's really strong.
Several answers are possible. It's not just one.
Yes, two of them. Unfortunately, the GoToWebinar platform was not really happy with the poll when I created it. So of course, there are more than one answer possible. Here, it's one, unfortunately.
Okay, you say the predominant one. Okay.
Yes, we will see the predominant one.
Yeah.
But you can absolutely comment, and it's completely true that there are many different factors. Okay, so it's not moving anymore, and we get the gist with the numbers. So I'm going to close it and to share the answers. Care to comment on it?
Yes. Yes, actually, the 4 factors can influence pain perception or expression. I also agree that pain experiences have a strong influence. But as you will see, sexual hormones have an influence. We know that women, for example, depending at their stage when they are menstruated, can have different pain levels, age also, and social gender norms. So all 4 were correct, and I thank you for answering.
So thank you very much for answering those quick polls. It's just the beginning of what you're going to see during the lecture. What we're going to do is now we're going to share the lecture that has been recorded by Professor Clair earlier, a few weeks ago. You're going to have a chat box in which you can ask questions. So of course, don't hesitate to ask questions in the chat box. We will see whether we do have time, and we may take a few of your questions at the end of the lecture. In the meantime, when launching the video, everyone is muted, and we will be back in about 50 minutes to take questions and to just wrap it up. So let's just sit back, relax, and enjoy the lecture. And we'll see you in a little bit less than an hour.
So good evening, my name is Carole Clair. I'm very happy to give this course on sex and gender in pain perception. We will see together that sex and gender matter. So I'm an associate professor at the University of Lausanne in Switzerland, and I'm also a medical doctor in general internal medicine. So I'm very happy to be with you tonight. And I also thank Septodon for the invitation to give this lecture. So the objectives of the following 45 minutes is to know how to differentiate the influence of sex and gender on pain. We will see this at different levels on pain production, perception, expression, and treatment. And you will also be, at the end of the course, be able to identify and prevent, hopefully, gender bias in the assessment and treatment of pain. So the agenda for the next session is first to define sex and gender. So these are definitions that we need to be aware of. And then we will discuss sex and gender differences in pain prevalence, sex and gender differences in pain mechanism, and in pain management. And we will finish with a conclusion and a discussion. So first of all, gender matters, and this is not a new topic. You see here on this editorial published in 2010 in Nature that we need as researchers, but also as clinicians, to put gender on the agenda. Biomedical research has been built mainly on male models, animal or human male models. And the consequence is that the evidence is less robust for half of the population, or maybe more than half, because it was also built on white middle-aged men. So we have less knowledge, less evidence on women, and this will have consequences, and consequences on all knowledge in pain management, and that is some aspects we will discuss later on. But first, let's talk about, well, let's define what is understood when we talk about sex and gender. So here I give you the definition from the Canadian Institute of Health Research. And when we talk about sex, we refer to a set of biological attributes in humans, but also in animals. So it's associated with physical and physiological features, including chromosome, genes expression, hormone levels, and function and reproductive sexual anatomy. So this is probably something very clear for you. We talk about male sex or female sex, and it's defined as kind of a binary variable, male, female. However, it can be more complex because we know that there are individuals with a variation of sexual development, the previously known hermaphrodism, and sometimes it's not that dichotomized, it's not that defined, and we need to be aware of this. But for today, we will keep it simple, and we will talk about male and female sex. Opposite to sex, we also have the definition of gender, which refers to socially constructed roles, behaviors, expressions, and identities of girls, women, boys, men, and gender diverse people. So as you see, the gender definition is much more complex, and probably also it varies. And we know that gender, as sex, influences how people perceive themselves and each other, how they act and interact, and it also can influence the distribution of power and resources in the society. Gender is interesting, but also difficult to define, because you can, when you think about yourself, you can be defined as with a male gender or female gender, as a man, woman. There are some people who define them differently, themselves differently in between. And this will have consequences on your way you will behave, you will dress up, you will interact with other people, but also on the way of how others will consider you. And this gender dimension can be very different depending on the cultures. So it's different to be a man in Europe, for example, than to be a man in South Asia. It also differs given the periods. So it's not the same to be a woman today than it was to be a woman 100 years ago, for example. So this is complex, and we will dig into this complexity with also concrete examples. And we tend to oppose sex and gender, but we will see that most of the time, and when we talk about clinics and research, it's very difficult to disentangle those two concepts, because as you see here, it's schematized, of course. You see the cumulative life course risk factors for non-communicable disease, so diabetes, cardiovascular disease, and you see in blue that sex-related biological factors have an impact. So you can have an increased risk because of your genes or your hormones. When we talk, for example, when we think about cardiovascular disease, women in premenopause might be protected thanks to their hormones. So this is the blue part, and this will influence your risk of developing disease. And you see it's already present from childhood and even from fetal life. And you see that the yellow part is the gender-related social factors. They will also influence your health. So again, when we think about cardiovascular disease. For example, smoking is one important risk factor. And being a woman, maybe not now, but in the 50s, was protective because it was not socially accepted for women to smoke. So this is gender, and this is influencing your risk of developing cardiac or cardiovascular disease, or maybe also lung cancers. So you see here that you always have both the influence of biological and social factors, and it will influence many, many different diseases through also, as you can see here, the environment. So I talk about smoking, but obesity is also highly influenced by gender factors, if you do physical activity, and of course socioeconomic status is also an important determinant of health. Now I will show you a short video, just to very briefly show you the impact of both sex and gender in health.
Meet Mira and Leo. They're both 55 years old and have chest pain. Leo goes straight to the hospital, where he's admitted for testing. Leo's a smoker and has a family history of heart disease. Mira doesn't go to the ER. Instead, she takes her heartburn medicine and eventually visits her family doctor when her chest pain worsens. Mira is healthy, but has been feeling stressed recently. Her doctor suspects she's having a panic attack and sends her home. Later that day, Mira collapses and is rushed to the hospital. Mira and Leo receive their diagnoses. Both have cardiovascular disease. We're the same in many ways, but when it comes to our health and well-being, differences matter. Sex and gender shape us inside and out, from cells to society. Cardiovascular disease is a leading cause of death for both men and women. Heart disease in women is often unrecognized, while men tend to develop the disease at a younger age. Why? The answers are complicated, but we can uncover them with better science. Whether you're studying cells, tissues, animals, or people, integrating sex and gender in your research is an opportunity for innovation and more rigorous science. An increasing number of scientists are accounting for sex and gender, and funding agencies around the world now require applicants to consider sex and gender in their research. But there's more to do. In Canada, 1 in 3 women die from cardiovascular disease, yet most preclinical studies are conducted on male mice. The causes behind the earlier onset of heart disease in men still aren't fully understood. When it comes to health research, sex and gender can be tough to tease apart, but they're different. Sex refers to biological attributes, including physical features, chromosomes, gene expression, hormones, and anatomy. Gender refers to socially constructed roles, behaviors, expressions, and identities. Think of Leo. If gender influences smoking behavior among men, and smoking raises the risk of heart disease, where does sex end and gender begin? Accounting for sex and gender in health research is about effective health promotion for Leo, and more personalized healthcare for Mira. It's about shaping science to create a healthier world for men, women, boys, girls, and gender-diverse people.
Okay, so this was a video from the Canadian Institute of Health, and I think it wraps up a little bit what we've seen about sex and gender. Okay, so now we are going to talk about sex and gender differences in pain prevalence. And we discussed this, and you answered the small survey, who is more sensitive to pain? So we will discuss later your results, but let's look at what data tells us. So I show you here data from Switzerland, but we probably have the same or similar results in most high income countries. You see here the prevalence of pain among men and women. So women in orange and men in yellow. And you see here for different kinds of pain, stomach, headache, shoulder, or back pain, women report more pain. Systematically, they tend to report more pain. When we look at consumption of painkillers, the same is observed. You see again, women in orange have a higher consumption of painkillers compared to men. And this is the case at all age ranges, so all age categories, where women tend to consume more painkillers. I show you now data from wider data from other countries. So you see here in this review, which was published in about 10 years ago, and you see here all the studies. So each bar is for one study that compared the prevalence of pain between men and women, and if the bar go up, it tells us that there is an excess prevalence in women. And you see again that for all kinds of pain, back pain, migraine, musculoskeletal pain, neuropathic pain, oral pain, osteoarthritis, and widespread pain, there is an excess prevalence of pain in women. And I think for you, which would be very interesting, is oral pain. And you see here, you have some studies, probably there are more studies now, but all suggest that women also report more pain. So this seems to tell us that there is a higher prevalence of pain in women, but is it true? Is it a true higher prevalence, or is it just that women tend to report more pain or to see their doctors or their healthcare providers or their dentists more when they have pain? So now let's look at biological study or laboratory studies. And here you see again a review of several studies that have been done. And these were laboratory studies where you basically take healthy subjects and you will expose them to pain. So you see here different kinds of pain. It can be electrical pain, ischemic pain, pressure, cold, heat. And then you see how sensitive they are, so how long they will tolerate the pain, how high they will describe the pain. And in these results, you see here that when it's pink, the pink bars show that women are more sensitive to pain compared to men in these studies. The green bars show studies where it's equal, and the purple bars show studies where men are more sensitive to pain. So again, you see here that for almost all kinds of pain and for pain tolerance, pain threshold, and intensity of pain ratings, women tend to be more sensitive to pain and report more pain. There are only a few studies, and these are minor, that show that men are more sensitive, and also very few studies showing equal sensitivity. So again, this goes in the direction of women being more sensitive to pain, but again, we know that it might not be just biological, but also how we are taught to behave. Our education might have an impact on how we can support pain. And it's complex, and as you know, pain is goes through different pathways, from first the signaling of the pain, and here we can have a modulation by immune cells, and we will discuss this a little bit later. We know that T cell and microglia, so these are immune cells, will modulate how pain is signaled. Then at individual level, we can have the perception of pain. So we will have the sensation of pain. We will recognize this as a pain. And this can also be linked to emotions. So for example, if you have a history of some pains, you might be less willing to support some pain because of a bad experience. And then after perception, there is expression. And we can express our pain with verbal. So that's typically what a patient does when we ask him or her to rate the pain, or to on an analogic scale to describe the pain. It can also have a motor expression and physiologic expression. And finally, there's the treatment. And here also we have different levels of treatment, with the choice of treatment that can be made by the healthcare providers, how quick we will treat some people, the dosage, and also how effective will be the treatment. And what is interesting with pain is that at all these different levels, from signaling to treatment, going through perception and expression, we might have an impact of both sex, hormones, immune cells, genetic predispositions, and gender, such as gender role, expectation, gender priming. I will show you a very concrete example later, and gender relations. So how is the relation between the patients and the healthcare providers? So it's a good example to really show how sex and gender have an influence. So now let's look at the mechanism. And here I show you a very good review article published quite recently in the journal Nature, talking about the pain gap. And what has been observed pretty recently is that there is a real dimorphism in pain. So there are differences, and this is based on animal models in the pathway of pain, especially some kinds of pain. And you see here, it's schematized here, that in those animal models who were injured and had a peripheral nerve injury, the pathways were different, with an activation of microglia in the male subjects, whereas female subject had an activation of T cells. So two different pathways. And what was observed in these models is that when they modified the mouse, in this case, these were mouse models, and they modified the males and developed males lacking testosterone, so who did not have testosterone, these male animals would switch to a female model, so more to a T cell activation when they were exposed to nerve injury. So that's interesting, and this suggests that hormones and testosterone has an impact on how pain, is processed. And this is something also we observe in human models. There might be difference in genetic predisposition. When we look at the concentration of receptors, opioid receptors in the periaqueducal gray matter, so in the brain, we see that there is a higher concentration and higher expression of those receptors in women. So this also suggests some really concrete biological or anatomical differences. We also have observed that in men, there is a better activation of the descending pain control. So that means that it's a process that is developed to control pain and also to decrease the risk of chronic pain. So this better activation in men, could also explain why they are less likely to suffer from chronic pain compared to women. And it's, of course, not everything is understood on why there is a better activation of this control, of this pain control. And when we look at hormones, I just explained you that these male models lacking testosterone were kind of changing the pathways. We know that testosterone activates the microglia and suppresses the T cells, so the more inflammatory markers, whereas estrogens activates T cells. And even in women, among women, we know that there is a variation of pain according to hormonal cycles. And depending, we know that there is a change in hormonal levels in premenopausal or in menstruated women. And we know that the pain threshold and tolerance of pain are higher in the follicular phase, so in the first part of cycles. So this really shows that hormones have an impact on pain and pain signaling, and also pain ratings in men and women. And this has to be taken into account. And again, this is important because maybe, and that might be future, we might develop treatments that are more effective for women or for men because they are developed on a model that is a better model. And as you see here, this is a figure showing the proportion of studies. So these are preclinical studies, so mainly studies done on animal models. And you see here that the majority of the studies are based on male models, so male only, the blue parts. Some of them, but a very minority of them, are based on female only. and very few have both male and male and female subjects. Some of them even do not report the sex of the subjects. You see here in orange. In gray, where sex is not reported. So again, this is important because, as we've seen, if we want to build evidence-based medicine, if we want to have evidence on the efficacy and side effects of the new drugs, we need to include mixed model, and we need to compare male and female, or to compare men and women in clinical study. And here I show you one example. So it's a very specific example, but I think it's also important to show you how far gender and sex can be important. And here, this has been presented by one colleague of mine, Dr. Schibinger, but it's based on research made by Professor Mogil in Canada. And what they have shown is that the staff or the researcher sex was influencing how mice would express pain. So basically what they did is that they just by chance observed that systematically when the mouse was in presence of a male researcher or male staff assessing the pain, they would show lower pain, and when they were in presence of female researchers or female staff, they would show higher pain. And that was really, this observation was made possible because they really had these differences of men and women, but they also look at the differences in male and female mice. And actually, this was the same. The sex of the mice did not influence the pain, but it was really the sex of the researcher that was influencing the pain. So they call this the male observer effect. And after many research and many tries, actually what they observed that is that this difference was mediated by the olfactory stimuli. So animals would detect pheromones that were secreted by the male researchers, and this would induce a stress on the animals, and this would explain why they would have lower pain scores when they were in presence of male researchers. So interesting. It's not just anecdotal, because then it could also bias the results, and we might wrongly think that some animals have lower pain scores, whereas it was mostly linked to the presence of the researchers. And of course, we don't treat mice, but if we do the parallel with our patients, we also know that being a man or a woman as a doctor can also influence how our patients will express their pain, and maybe they feel more comfortable to say that they have an important pain where they are in presence of a male or female doctors, and we need to be aware of this. And then looking at, again, at differences in pain, we know that on average, and this might vary depending on the cultures, but on average, men may be less willing to report pain than women. And women are expected to report pain more readily. And this is in part explained by gender roles and norms. And we know that the masculine norms tend to associate male identity with toughness and stoicism, while feminine gender roles are more associated with emotionality and gentleness. So this is not sex, this is really gender, and these are gender roles or gender norms that have been defined by the culture, and that might change also in time or depending on the country where you're in. But this is important because this can have an influence on how we are raised, and we know that from childhood, really boys and girls are socialized to respond differently to pain, and young boys, and I tend to still see this in my practice, young boys tend to be taught to be tough and to not to tell that they have pain, and young girls are more expected to report their pain, and it's more easy for them to report the pain. So this is important because this might also explain why, how we have seen previously when we look at pain prevalence, how it could influence, because maybe there might be an under-report of pain among men because, again, they have been socialized to not to express their pain. Now, when we look at beliefs of healthcare providers or even of the general population, what has been shown, and this is a bit old, you see here, it's from a study from the 2001, and this was done among students in the United States. But in this study, they kind of looked at the beliefs on pain, sensitivity, endurance, and willingness to report pain in men and women. And what was observed is that men are considered as more resistant to pain in this group of students. So when we ask them to rate how endurance to pain and how willingness to report pain the men and women are, both female and male students tend to say that men are more endurant to pain, so they will tolerate the pain longer compared to women, and they are also more likely to report that women are more willing to report pain. So we have these beliefs, but we will discuss your results later. This might be different. And for example, in Switzerland, we tend to, when we ask physicians, and we did a small survey also among emergency physicians in our area, they really thought the opposite, and most of them would say that they think that men are more sensitive and less willing to report pain. So again, this is gender, and this is highly influenced by social norms and beliefs. But this, again, this matters. And here in this meta-analysis, we see the correlation between female and male personality traits and pain sensitivity. So you see here different studies which really correlates this personality traits. So again, here there is no hormones, no genes. It's really if you are more like female or male regarding your personality and kind of stereotypically what is expected for men and women. And what they showed here is that the more women or female personality traits you have, the more sensitive to pain you are. So there is this correlation. And even more interesting, studies have shown that you can modulate the pain perception by modulating also these gender beliefs. And in this study, which was performed in Germany with 120 men, so men only, what they did, and it was really clever, is that they separated this group of men in two. So the first group was told that men were less sensitive to pain than women because of their evolutionary role as hunters, so they were more robust and more tolerant to pain. So that was the first group. And to the second group, they said the contrary, that women were less sensitive to pain because of the painful process of childbirth. So they really gave the other message to this group of men, that as men, they would be probably more sensitive to pain because they will not give birth. And so that's why they don't have such pain tolerance that women have. Then what they did is that they exposed these two groups of men to pain stimuli. And they observed actually that men in the first group reported less sensitivity to pain when they were exposed to this pain stimuli compared to men in the second group. And there was also a control group which was not told anything. So you see here, when they asked men to rate the pain when they were exposed to pain stimuli, they would really, the group that was told that they were more sensitive to pain, they would really express more pain compared to those who were told that women were more sensitive to pain. And this was also correlated with changes in imaging, brain imaging, MRI. So really showing that it was activating different, well, there was really an observation, and it was really correlated with a stimulation in the brain. So that's what they call gender priming, and it's interesting because we see that we can, based on the stereotypes or the knowledge or beliefs that we have, it could modulate how tough we are regarding pain. So now let's look at pain management. We've looked at the prevalence, we've looked at different mechanisms, so that can be influenced by both hormones, sex, and genetics, but also by gender, as we've just seen. So now, what influenced the pain management? And what studies have shown is that, again, it might depend individually, but what we observe is that on average, healthcare provider might treat their patients differently, and they might be more likely to classify pain as psychological rather than physical in women. And they tend to also, then we will see, treat women later or wait longer to give them pain treatment or painkillers. What is also known is that men who suffer from chronic pain might find their masculinity questioned. So again, we have all those beliefs that chronic pain is probably more something that is related to female traits, and we might then attribute some gender traits given the fact that a patient has some kind of pain. And as a consequence, and this is in acute pain management, we'll see that it's different in chronic pain. But what has been observed, and this is mainly based on studies in the United States, is that men receive more opiate-type painkillers for acute pain, and women wait longer in the emergency room to receive analgesics or painkillers. So they tend to wait more than 1 hour versus 50 minutes for men. And women also receive more psychotropic drugs. Again, we have seen that there is this tendency to psychologize the pain when it's a woman. So as a consequence, they also receive more psychotropic drugs. And this is this study where you see the difference in opioid administration by patient sex, but also by provider sex. And you see here that on average, male patients here in blue tend to receive more opiates than women or female patients. And there was not a huge difference when we looked at the sex of the residents or attending physicians. You see that this tendency to treat more aggressively, so to say, male patients, is really not dependent of the sex of the physician in this situation. And that's also what we observed in the few studies I've done with our emergency doctors and also with our residents, is that usually the stereotypes are shared, but we'll see that it's not always the case. Now, looking at chronic pain management, we talk about acute pain. Here, it's a little bit different. Women with chronic pain are more likely to be prescribed opioids than men. So maybe, again, this is related to the fact that acute pain is considered more like a male symptom, more and chronic pain, we know that there are more women. So again, we might maybe change our attitude given the type of pain. We know also that women, as a consequence, have a higher risk of developing dependency and overdosing on prescribed opioids, but overdose in non-prescribed, and sorry, I should have written this, but deadly overdose in opioids are higher in men. So that's probably also a difference, that women have more prescribed opioids, but non-prescribed is more frequent among men. And we know also that the management, and this is another topic, but the management of opioid use and misuse is better for men. So they are better screened, and they are also more likely, they have a higher likelihood to be referred for opioid use disorders. Male patients have a higher chance to be managed correctly compared to female patients. Now, this is one result. I could find very few results specifically on dental care, but in this study, again, looking at the gender roles and the role of the gender of the healthcare providers, on pain beliefs. And here you see that there were almost 90 dentists and 80 physicians. 40% of them were women. And again, we asked them to tell if they believe that men or women are more willing to report pain. And you see here that in this group, we observed not the same as what was observed. No, sorry. We observed the similar what was observed with the students. They tend to say that women in gray here are more likely to report pain compared to men. But then when we looked at the discipline, that was interesting because it was different. And here, when we look at dentists, we looked at it was especially female dentists that were thinking that women were more likely to report pain, but it was not so the case, and probably it was not very pronounced, and even maybe the inverse among male dentists. So that might be something here to understand. Again, it was a small study of a small sample, so I think we cannot drive strong conclusions, but it's interesting to see also that this might differ given the specialty. Then when we manage pain and when we manage more generally our patients, we need always to be aware of two types of gender bias. First, the gender blindness, so to think that there are no differences between men and women and to treat them similarly. And we have seen that in some cases there might be differences because of hormonal levels, because of weight or size, and it's really important to be aware of the differences and not maybe, but to take them into account when they are here. On the opposite, we also need to take to be aware of gender stereotypes. So this means to think that there are differences between men and women when they are not. And so that's that's the difficulty, because in some cases we should treat men and women similarly, and we should not make differences. Otherwise, this would apply stereotypes. And I will show you a concrete example later on. So that's really the question we have to, and I think we deal with this maybe automatically, but we need to think about, okay, do I do a differences with these male and female patients? And if I do a differences, is it justified? So that's important then to not fall into stereotypes. And here I show you a small study that we performed in Lausanne with the university, the students of medicine from my universities. So these were first year master students, first-year master students. And what we did is that we infiltrated the exams. So at our university, I think it's the same for most universities, students have those objective structured clinical examinations. So they are in presence of comedians or actors who play the patients, and it's very, very formalized, very similar cases. So they have all the same script, all the same story. And what we did is that we infiltrated the exams, and for one situation, and I show you here the case of anxiety disorder, we exposed the students to half of them were exposed to the male patients and half of them were exposed to the female patients. And what we observed is that they really tend to manage and to, well, not to manage, because here we ask them what is the diagnosis in this patient. And you see here that 26% of the students would put the correct diagnosis of anxiety disorder when the patient was a woman, but only 12% of them would put the correct diagnosis when the patient was a man. And again, this was the same history, the same symptoms, the exactly same script. The only differences was the sex. So that's interesting, because here it shows clearly that we might have stereotypes. We might believe that anxiety is more a female problem, and in this case we might under-recognize anxiety in male patients and probably under-treat them also. So that's one example I use often also to sensitize students, but also teachers about those differences and which could have really concrete consequences. And talking about consequences, here again, I take another study that we performed and published recently using hospital data for acute coronary syndrome in Switzerland. So you see here we had more than 200,000 patients, and we looked at the management for men and women. So very simple question: if you're a man and you have a heart attack, or if you're a woman and you have a heart attack in Switzerland, is your management different? And what we observed is that it was really different. You see here, when we look at thrombolysis, percutaneous coronary intervention, or coronary artery bypass graft, which are all treatments, men were more likely to receive those treatments compared to women. So you see here men in light color and women in darker blue or dark green. And this had real consequences, because here below you see that women are hospitalized longer, they are less likely to be admitted to the intensive care units, and they are more likely to die. This is in hospital death, and you see that we have a 7.5% death rate in women compared to a 5.2% death rate in men. So this is an important consequence. But one important variable here was age, because we also know that women have a heart attack at a younger age than men. So what we did further is that we stratified our results by age. Here I will not go into all the details of the outcomes that we looked at, but let's just look at deaths in hospital. And when we look at younger age group, women younger than 50 years old and women between 50 and 65, you see that women have a higher mortality rate compared to men. This is again in hospital mortality. And then when we look at older women, it reverses. So this tells us something about these younger women, and this is to make the link with the stereotypes, because of course more study and more research is needed. But one of the reasons why younger women had such a bad prognosis is probably because they wait longer to have the diagnosis. They are less likely to have the treatments, as we can see here. Again, they are less likely to have the coronary artery bypass graft or PCI. And this really has concrete consequences on the risk of death. So I will finish with this. We need to be aware of our stereotypes. Of course, it can be useful because in a consultation, there is interaction with our patients, and we need sometimes to categorize our patients. But then it can be problematic if we make implicit association based on sex, gender, but also other determinants of health. So this could lead to, for example, for pain, to wrongly believe that one group is more sensitive to pain or more resistance. And this could lead to discrimination when this has really a negative impact on the care of the person and on the management of the person. And what is observed, and we did this work together with a general practitioner in our institution, is that those biases are everywhere in our consultation. So already when we take the patient history, we know that we tend to explore more the psychosocial context of women and more the work context of men. So we just need to be aware of this, and we can correct this in most of the cases. We also observe bias in physical examinations. So, for example, women are less examined or have a poorer examination of the chest because also of the discomfort that some physicians might have in physical examination. Again, with the diagnosis, we can have a differential diagnosis, as we've seen with anxiety, that can be based on sex-specific prevalence, but that can bring a risk to underdiagnosis. Here, the example I showed you, it was in disfavor of men. So also to show you that gender is about women and men, and then gender bias can also be in disfavor of men. And then management, and we discussed largely pain management, can also differ given the sex and gender. and as also patient's perception, and we discussed the male observer effect. This can be influenced by the sex or gender of the healthcare professional. So if you want to test your own bias, I really highly recommend you to do this test. You can go on the website implicitharvard.edu, and here you have all different kind of tests to see if you have bias or if you have stereotypes. And there are two tests about gender. One looking at the association between gender and career, and the other about the association of gender and science. And just to show you an example, I did this test. So I just looked at how biased I was regarding the association of male sex with career and female with family. So I'm working in the area of sex and gender for about 15 years. I'm a mom of 3 girls. I'm very involved in also career for women. And these are my results. So I had a moderate automatic association I was associating male with career and female with family. So again, which shows that we all have our socialization, we all have our representations, and I think that's really okay, but we just need to be aware of them and maybe to try to work on them. And to finish, also just we discuss about sex and gender, but there are many other factors that can influence pain, such as age, ethnicity, culture, comorbidities, ability, drug use, social support. So we always need to think about all those other factors, and this is what we call intersectionality, because sometimes they will accumulate. So, for example, being a woman and being a Black woman might be a higher risk of underdiagnosis or undertreatment of pain. So to conclude, we have seen that the prevalence of pain is higher in women globally. Women are more sensitive and less tolerant to pain compared with men. But this can be explained by biological differences, but also by gender differences. So we really talk about the sexual dimorphism in pain, but also on the influence of gender and gender norms on the expression of pain and on the management of pain. So taking sex and gender into account is important in pain management, and this can improve the quality of care for all patients independently of their sex. So if you want to go further and to read more, I also recommend this report, Gendered Innovation, which really gives concrete example on why and how to integrate sex in research, but also to bring innovation. So this is more for research. And you also have this website, which is really well done, Gendered Innovation, where you could also find some resources and some examples. So I thank you for your attention, and I am now ready for discussion and comments. Thank you very much.
So we are back. Thank you very much for following this this webinar with us. Thank you, Professor Clair, for coming back. Yes, you're unmuted. So we hope that you all really enjoyed this webinar. We had a lot of comments, not a lot of questions. So if you guys want to ask questions, now is the time. But we did get a lot of comments, and maybe a few comments that you can comment on. Well, first of all, everyone's really interested in getting a copy of that lecture because it's been quite interesting. So you will receive a recording of the lecture sometime around next week, and also a very good question just arrived now. How many attendees are women versus men? So this is this is something I can a ratio I cannot give you right now, but this is something that I can give you in the with the recording. I will be sharing this information because it can be something quite interesting. There was one comment about how women are used to bearing menstruations from a young age, and how this can impact the feeling of pain and the way that they just have to bear period, and versus men who really don't have the same type of pain. Care to comment on that?
You want me to react, Cécile?
Yes. Yeah.
Yes. Yes, thank you for this comment. I think that, of course, it's always multifactorial, but this, of course, can be a reason why women probably navigate with pain. Not all women, of course, not all women will have pain when they menstruate, but a large proportion of them will have pain, and that can be one exposure to pain from the very young age. And I think also what is interesting with this example is that also given the type of pain, we might take them more or less seriously. And I think pains that are related to periods tend to not to be really considered as pain. And it's one example is endometriosis, which is a disease that is about 10%. The prevalence is about 10% in women, and usually it takes about 7 to 10 years to diagnose the disease, because it's just considered as normal that women have pain when they menstruate. So yes, I think that's one example, and probably we will be more or less attentive to pain depending on the type of pain.
Great. Thank you very much for answering that comment, more than a question. So yes, regarding the attendees, I just created a poll to know whether are you a man or a woman, just to have that answer.
We can guess.
Yeah, if you're still here, can you please answer that poll so we can check, and we can just have that little last information. And this is something that will be shared along with the recording when you get the recording of this webinar. Do you have an idea, Professor Clair? Do you know if there are going to be more men or women as attending?
I would guess that there would be probably more women. It's usually what I see, and gender in health. But yes, I think it's as I've shown, it's a topic that is also touching men. So there are more and more men interested, but still most of the time people yes, consider gender as being something female or women-like. So we'll see. Maybe I would be surprised. It depends also of the proportion of dentists. I don't know what is the proportion of practitioners, of the male-female proportion.
Two-thirds of the audience has voted. So if you want to share your gender with us, okay. I stopped.
Yes, you also can. Yes, you're not. Yeah.
And yeah,
interesting.
Not a surprise.
No, but you know how many? Well, it probably depends the country, but the proportion of male-female dentists, I don't know.
Yeah,
it's
maybe,
probably not proportional.
Yeah, maybe that can play. That can play as well. Thank you very much, everyone, for playing along. There are a few questions that keep on coming. Quick question: are there any ongoing trial or studies with gender and pain? Are you yourself involved in any studies?
Yeah. Yes, well, we just are now beginning. Sorry, I can understand. I have an echo, but it should be okay.
It's fine with us. I mean, I
okay.
can do very well.
Okay, so we just begin now a study with it's more the emergency department, and we, you know, the nurses are trained to for the triage. I don't know how to say this in English, but you decided for the patients if they go to the very emergency room or if it's not that urgent. And they are trained with serious games, you know, those kind of videos with where you can kind of modify the patients and they interact. So it's more like AI or and what we will do here is we will really in kind of this safe experiment space just it's really those usual situations they are trained with, and we'll just modify the gender but also modify the ethnicity, the age, migrant status of the patients, and see if it modifies the way the nurse evaluates pain, or the way they will decide which patient needs emergent care and which does not. So that's one study we are about to begin. And yes, and it's really an ongoing process. I have also a colleague who's doing basic research, so he's the one working on T cells, and that's something that is really growing fast.
Great. Can't wait to see the results of that. There's another question. Which score do nurses use to evaluate pain, or will they use to evaluate pain? Is that the visual analog scale?
Yes, yeah, usually it depends the studies, but most of the time these are the visual and analogic scale. And of course, I think there is no perfect way of evaluating pain, because pain is something very subjective. So
it's the one that we can compare. I think we lost Professor Clair.
You cannot really, well, of course, heart rates might increase when you have pain, blood pressure too. So
okay. There's a question about different cultures. Are there in the studies that have been done or that you may know of, are there cultures in which the gender bias is not as important as in others?
That's an important question, and I think yes. Well, maybe not specific to pain, but we see that in some cultures, yes, there might be differences, and gender or the roles of men and women might be different. So there are not that many studies, and I think also it's not that easy to do. But I think yes, it might change depending on the culture. But what is kind of when we look at for example, some of the discrimination, we tend to see this reproducible in different settings, even though, for example, we look at Europe or the United States, but you know, that tendency to give less painkillers to women is really shared, even though we are in different continents. So it's not an easy question, but I agree that and I think the culture might differ and have a different influence. Yeah.
Great. There's a question that's more about local anesthesia in dentistry. So this isn't something I think that you might be able to answer, but I'm still going to ask it, because then we will maybe get the information from someone else later on. Is the effect of local anesthesia influenced depending on the hormonal stage of a woman?
Yes, I will not be able to answer, but that's a good question, and maybe you will find studies. I had really a quick look, and I could not do a complete literature review, and I would probably not be able to interpret the results very correctly because I'm not a dentist. But that's something, yes, that should be checked. Yeah.
We do have some dentists we work with who are really interested in women pain, and maybe able to give us an answer or do a literature review on this. So interesting question, and that could be answered afterwards.
Yes, my guess would be that there would be probably a difference. not because of the effects of the local anesthesia, but because how women perceives pain, just as we have seen, because the pathways might be different and you might be more sensitive to pain at a different period. So I guess yes, but yes, I don't know if you should like treat your patients depending on their periods. That could be a good study.
Yeah, that's the link to age and to previous experiences and to what you felt in the past and the threshold of pain that you felt in the past. It's known that when women give birth, you kind of push your threshold of pain, so maybe the experiences afterwards will be a bit different as well. So it's a different stages in life. There were many comments saying how good this presentation was, so thank you so much, Professor Clair, for being with us today. This shows that while education or information is still very much needed, that this is quite interesting to some people to understand better how to treat and how to juggle with pain for men and women. So as I said earlier, we will share the recording, so you will have the lecture handy, and you will get an email after the session. When you close the webinar, you will get a satisfaction survey. Don't hesitate to answer. Did you like it? Would you recommend it to a friend? We're very happy to hold this kind of webinars. Professor Clair, thank you so much for being with us tonight. Is there anything else you want
Thank
to
you for
add?
the invitation.
No problem.
No, thank you for the invitation. Sorry.
No problem. It was a pleasure to have you here, and we hope to work with you again. Have a nice day, everyone. Have a nice evening, and stay tuned for the next webinar from Septodont.